Hi, Dr. Tennant.
Hello, hello.
Welcome everyone to season 4, episode 19 of DocToks with Dr. Poorest, Tennant and friends. Oh, Doc, please go ahead and take it away. It's all yours. Thank you so much.
Yeah. Thank you, Jamie. It's good to be here. We have an exciting guest and a little unusual orientation with the guest here later. But what I want to start off with today is a sort of a topical discussion, and that is COVID and intractable pain, and particularly as it relates to arachnoiditis and CRPS and fibromyalgia, EDS, and all the conditions that we deal with. We haven't really talked about COVID much on this show, but the COVID inquiries have been coming into our foundation, frankly, on an increasing basis. And what I want to do is start off with telling you that the reason we're doing this is because we haven't received an overwhelming number of reports, but we've received a fair number of reports of people whose intractable pain condition, particularly adhesive arachnoiditis and multiple sclerosis, has worsened either after the acute infection or after a vaccine or as what they're calling long COVID. Okay. So again, make no mistake about it, we are like other people in the country, have seen COVID both acutely with the vaccines as well as with the long COVID, causing an increase in symptoms and problems in people who have intractable pain, and particularly adhesive arachnoiditis. Now, I want to, first off, I want to make it very clear that one of the reasons I'm going to talk about this evening is because we have the usual misinformation, over-exaggeration for different vested reasons. Now, we are getting misinformation on two fronts, the opposites. There are certain parties in the country who are saying this whole thing with COVID, long COVID, is irrelevant, doesn't exist, it's minor if it does exist, it doesn't mean anything. And then we have the polar opposite, in which we have factions saying this is a terrible problem, it's involving millions, we need to have more funding, we need more of this, more of that. And these people obviously have some financial or political agenda. The truth is, as usual, somewhere in between, okay? In other words, it does not want to be taken lightly, but from what we can see, there are rare cases of where COVID has really caused problems, particularly in people with multiple sclerosis, but it's also caused some real problems with people with adhesive arachnoiditis. Now, let me talk about what's happened with the arachnoiditis patients that we've seen with COVID complications. The worst one is that pain gets worse, and secondly, the paralysis gets worse. So those have been the two things that have been the most worrisome: more pain, more weakness of legs and arms. Now, that is a very sad situation. We've got a handful of cases in which the paralysis has not gone back to normal and the pain has stayed up. It didn't go back down to its baseline. So we have seen some problems that we don't like one bit. Now, the other thing that they're not telling anyone about is, how does COVID cause these problems? And you would think by listening to the media that they've never seen a virus do anything like this. This is all nonsense. Now, let me give you a little history about viruses. Having post-viral complications is hardly new. This is hardly anything that we don't know about or is brand new. They keep trying to tell you this is a brand new thing, never happened before. That's nonsense. The first big problem in this country occurred in 1918. There was a flu epidemic, and its major long complication, or its eternal complication, was the cause of Parkinson's disease. When I went to medical school in the 60s, if you had Parkinson's disease, we assumed you had had the flu of 1918. Now, the second big thing in this country, it's like it's been forgotten, polio. I mean, polio had lots of complications, a lot more than COVID, and it was paralysis, paralytic polio. As a matter of fact, I broke into treating intractable pain in the 70s because we had a lot of people who had intractable neuropathic neurologic pains due to polio. So this is nothing new. This is nothing new at all. As a matter of fact, one of the things that I'm going to mention in a minute, I'll say it to start with, viruses like the nervous system. They like to invade nervous tissue. Apparently, it's sort of like dogs after a nice juicy bone. Viruses like nerve tissue to invade and to cause problems. Now, after the polio thing, one of the next things that I was very involved with was West Nile virus. It caused a type of headache that was just terrible. It wasn't a migraine type, it was just there and didn't go away. And it was terribly severe. A lot of these people had to take opioids and still do. And so headaches after post-Nile infections were not common, but that was its long complication. And of course, the one that everybody knows about, if you've had chickenpox, its long complication is called shingles. Okay, you may have had chickenpox when you were 10 years old, and you end up getting shingles when you're 50, or Bell's palsy. So anyway, we've seen this in the past. So COVID, in a way, is really not a lot different than other epidemiologic viruses that we've had in the past century. It invades the nervous system and may cause long-term effects. Now, how does it cause these long-term effects? We're not certain exactly. Two reasons why the COVID can be long, if you will. One is it can just simply invade tissue. Now, exactly why viruses start off acutely, causing all the symptoms, and then kind of calm down and stay inside the nerves is not really quite understood, but it does do that. The virus goes from an acute stage to what we call a dormant parasitic stage. And COVID appears to be in that same category with a lot of other viruses. You start off with the infection, and then you have a virus that settles down either in your lymphocytes or your nerves or your thymus or your spleen or somewhere in the body and continues to cause some symptoms. The other thing that I really want to emphasize is that these viruses act in synergy. Now, a lot of you are well aware that we've been trying to educate the world here on the hazards of the Epstein-Barr virus. And as far as we can tell, the Epstein-Barr virus is still the lead virus. And that a virus like COVID can activate the Epstein-Barr virus. Now, one of the things that caused us problems in figuring out which viruses were causing intractable pain is we started taking these blood tests, 20 years ago, and people would show up with more than one viral titer that was high. In other words, they ended up with not only the Epstein-Barr viral titer high, but their paravirus titers might be up, their Coxsackies, their herpes 1 and 2, and then along comes mycoplasma, which is really a bacteria, and Lyme, which is a bacteria, also were up high. The bottom line is we don't quite know how these viruses work, but they work as a team. Now, the Epstein-Barr virus is kind of the quarterback, but he's got a whole front line out here of these other viruses. Cytomegalovirus, for example, and now COVID. COVID is just another one of a half a dozen viruses that seem to be come together in some kind of a pattern or some kind of a coalition in which these viruses pool together cause a lot of autoimmune disease. We do know that the Epstein-Barr virus tends to be the lead virus. We have not yet seen a documented case of adhesive arachnoiditis. We're up to looking at over 200 cases who does not have elevated antibodies to the Epstein-Barr virus. So we know that now it's almost like If you don't have an high elevated antibodies to the Epstein-Barr virus, we doubt that you've got adhesive arachnoiditis. You may have pain and some other neurologic problem, but we haven't seen a case yet. We'll probably see some along the line because there's no reason why other viruses can't do this. Now, we've got some cases of small fiber neuropathy, CRPS, and what have you that do not have positive Epstein-Barr virus antibodies, but they don't have adhesive arachnoiditis. In other words, adhesive arachnoiditis and Epstein-Barr are kind of the one things you don't want in life. They're kind of the end of a long, hazardous road. Now, what do you do about this? In some ways, I will say that the COVID has done one other thing which I'm happy about, and that is a whole lot of people have finally figured out that the corticosteroid known as methylprednisolone works inside the central nervous system. And the only other one that does is dexamethasone. Now, for example, there are some people who have had multiple sclerosis, had the viral COVID vaccine, or had COVID, and they've started to demyelinate, means the covering of the nerves is starting to unravel. They're going blind, headaches, more paralysis. And the treatment is intravenous methylprednisolone, somewhere from 500 to 1,000 milligrams by IV injection for 3 to 5 days. And so if you have intractable pain, you've got adhesive arachnoiditis, CRPS, severe pudendal neuropathy, and you've had COVID and you're getting a lot of increased symptoms, one of the very best treatments is intravenous methylprednisolone. Now, why methylprednisolone works and prednisone doesn't, or hydrocortisone doesn't, is because inside the central nervous system, there are things called the receptors that specifically will only act on this one corticosteroid. Now, that's the severe case. If you've got a real severe case, intravenous methylprednisolone is really the treatment. Now, let's say you've got some mild symptoms. Okay, you've got a little more pain with your pain problem. You've got some headaches. You're a little dizzy. Your appetite's gone. You're depressed. Your memory's hurt. Any of these symptoms, one of the first things I'd recommend is a 6-day Medrol dose pack. Now, Medrol is just the trade name for methylprednisolone. You can't hurt yourself. That's the standard treatment. You give it a go. But to close this out, I do want to make a statement. I've got two things I want to make a statement before Mark and I interview our guest. The backbone of adhesive arachnoiditis treatment for some time, and when this treatment kind of came to the forefront, we didn't know about all the viruses. But one of the things that controlled and still does the best treatment for adhesive arachnoiditis is intermittent, low-dose ketorolac and methylprednisolone. Now, ketorolac, Toradol. Now, half the doctors are still scared to death of it because they've been told it's a terrible drug. Well, that's not true. But it's the only anti-inflammatory we have, with the possibility of Celebrex in some people. It's the only anti-inflammatory agent we have that consistently crosses the blood-brain barrier, enters the spinal fluid, and will cut down inflammation inside the spinal canal and the brain. And you put the two together, low-dose intermittent ketorolac and methylprednisolone, those people tend to have the very best outcome with adhesive arachnoiditis, and certainly that should be the treatment for people with long COVID, at least for a while until the symptoms go away. A couple of other agents that are being used in long COVID that I'm very high on, one is ivermectin. Ivermectin's turned out to be an excellent drug. It was controversial when it was used with acute COVID. This was back in the days of misinformation, controversy, lockdowns, politics, and ivermectin was given a bad name. But it's a good, safe drug. Its clinical indication is parasites. These parasites, like Epstein-Barr, are parasites, and it's a good drug for them. So I'm quite high on ivermectin as a trial in most of these cases. One last thing before we call on our guest. In dealing with the Epstein-Barr virus, we're having a problem. And it stems from the fact that most of the research were done with PhDs in laboratories, in the research laboratory with the mice and the test tubes. And then you've had what you call your laboratorians, they're good PhDs. So all these good PhDs are out there doing things. The catch is the reports on the Epstein-Barr virus they're misleading. Okay, they're misleading because they come back and they say negative. Now, if you look closely, that's going to be what's called an Epstein-Barr IgM antibody. Okay, now that M, you might as well, it's not what it's for, but it really means, for simple terms, think of that as mononucleosis. So all us adults are going to have a negative IgM antibody, and a lot of doctors say, oh, well, you don't have it. He's right in the sense that you don't have infectious mononucleosis, but that's not what we're testing for. In a chronic pain patient, what we're testing for is, number one, have you reactivated the virus? Now that takes a test like what we call the early Epstein-Barr nuclear antigen test. It's the early test, and there's a couple of others, DNA and PCR, which sometimes can be used. But that's reactivation. Now, that's important. But what's really important and what's not being understood is that the antibodies to the capsule, that's called the VCA, viral capsule antibody, and the nuclear antigen known for nuclear antigen antibody, those levels are come back high. But the laboratory will say, this means you had Epstein-Barr in the past. Well, that's true. But it doesn't tell you that when those things are sky high, part of those antibodies are carrying autoantibodies. And that's what's destroying your tissues. And so I hate to put it this way. The interpretation of the Epstein-Barr virus test is complex, complicated. You need a seminar to understand it. And I'm not quite sure how we get all this across. The doctors finally understood all the different varieties of cholesterol and lipids, and they'll eventually get this. But it's very frustrating right now because the laboratory reports are misleading in the sense that they don't ever mention autoantibodies or the levels once it's above normal. Anyway, we're plugging along on this, and I want to move on because we've got a couple of important things here. Let's see, Jamie, do we have our guest here tonight?
Yes, sir. Welcome, Michelle. Welcome to DocToks. It's great to have you with us.
Hi.
Hi.
Okay, all right, Michelle. Okay, Michelle, I'm going to say a few words about you. Michelle and I have been in quite good contact here lately, not over good things, but over some bad things. She is a mother of an increasing number of children who are developing adhesive arachnoiditis and who may have Ehlers-Danlos syndrome. We have now received one report of an infant under 2 years old who has adhesive arachnoiditis, and several other children. And pediatricians have never seen it. Neurologists have never seen it in a child. But because of the MRI, and we know the symptoms, it's out there. I don't know how many children have it, but Michelle has been with it with a daughter. And Michelle, I'm going to let you start off with your story. I just wanted to know that this is the first time we've had even a mention of a child with adhesive arachnoiditis on this show, but your message should be heard by parents out there and other mothers who've got children with odd symptoms. Anyway, Michelle, start off and tell us a little bit about where you live, about your daughter, and get started with your story.
Sure. I live in the Midwest, and so I'm in an area that has, we have good medical care, but we have to travel to see specialists. My daughter is 17 now. She is a senior in high school, and she is, I'm a crier, so I'm gonna try not to too much, but
you got it right.
Your tears are welcome here.
Yeah, there you go.
well, I just don't want it to be ugly crying, okay?
Well, there's no beautiful people on this thing anyway, so don't worry.
Thank you. Yeah, so she is a resilient girl. She's always been just like I guess strong-willed would be a good word. I wanted to point out some of those strengths because that has been pretty evident through all this, how strong she is. Yeah, she's like, her strong will as a toddler was really hard, but I'm glad that she has that.
Let's start with this. She's 17. Tell me the very first day, week you noticed something wrong.
Right. Yeah. So her 8th grade year in January of 2021, we're a year into the pandemic, and she started complaining about her back hurting. We let it go for a while and then eventually took her to a chiropractor in like early February. She said if she doesn't feel better the next day to go to walk-in. And so we did, and the walk-in doctor did an x-ray and saw spina bifida occulta. And so I'm a pediatric occupational therapist. I know a little bit about some medical stuff. I thought, well, for sure she's got a tethered cord. This maybe isn't so bad. But then we had the MRI, and they that noted an arachnoid cyst. We have no idea how the cyst formed or how the leak started in the first place. So that year she had a surgery to fenestrate or cut the cyst, and that was it. She got back to a level of functioning that was tolerable. She wasn't in a lot of pain, but she just was not gaining back mobility. Her physical therapist was like shocked at, like, this is not right. So we got a second opinion 2 years later, a year and a half later, and that neurosurgeon said, yeah, we need to take the cyst off. So in June of last summer, 2023, she had the cyst removed.
And how old was she then?
She was 16.
Okay.
16, and when he removed the cyst, he couldn't identify the pinhole that was forming the cyst. He threw down glue and I don't know what else, and hoped that he closed up the hole. It didn't. It leaked, and it formed a pseudomeningocele. And so then she was in pain and had headaches. And she had multiple MRIs, but prior to the June surgery, she had a CT myelogram, so a spinal puncture. And then again in August, late July, she had another one which identified the pseudomeningocele. So then August of last year, she had the third surgery to close it, and he could see it because it had torn by then. He could see on the right side and in the anterior front part where that leak was forming. So that got closed, but then never regained the, like, being back to normal, because she was just in pain after that constantly. So that took us down a road of, who do we see to figure this out? We saw a physical medicine and rehab PM&R doctor who didn't know what was going on. We saw a pain anesthesiologist. He didn't have a clue. Then we saw a neurologist, and then, so this is now this year, 2024, in the summer. And so we saw the neurologist, and then coincidentally, the next week, her occupational therapist took a webinar on Ehlers-Danlos by a physician's assistant in California. So through all that, got that physician's assistant's number, called her to be like, we don't know what the heck's going on. There were things that, because she talked about the Medrol pack and some other things that might help my daughter. And so I did a call with her, just kind of a courtesy call that she does. And she's like, you need to look up Dr. Forrest Tennant's work. And so that's what brought us here. So I was the one that had to find it. It wasn't, I did call the neurologist afterwards. I'm like, hey, never mind. You're not going to send us to this other specialist because we have to figure this out.
Now, quick question. Now, does she have Ehlers-Danlos syndrome?
Not that I know of. I don't know for sure. She does have the, the titers for Epstein-Barr, but I don't know. She had the spina bifida occulta. I guess she has scoliosis that we didn't know until a follow-up x-ray. Yeah, and so that's kind of what got us here. We're just kind of luck found.
Now you've expressed the view that you feel that you just didn't get the right care or the right diagnosis, right concern. You've had some hostile feelings about this whole process. We don't want to ask you to name names or anything like that, but can you tell us what bothered you as a mother throughout this process?
Well, so the follow-up with the neurosurgeon should have been, we need to figure this out. And it was like, oh, well, we could refer you to our pain clinic, and we weren't impressed with pain management we had while she was hospitalized. So it was like, yeah, no, we don't really want to go there. So it was me that reached out to you, sent you all the MRIs, and then messaged the neurosurgeon like, hey, do you think this could be arachnoiditis? And at that point, so this was August of this year, he and a neuroradiologist re-looked at all her MRIs and then agreed with the diagnosis. So yeah, so not quite sure why a neurosurgeon wouldn't know that.
Okay. What would you have liked to have seen happen?
Well, I think from the start, like her first neurosurgeon should have been noting the abnormalities in her MRIs and encouraging us to move forward faster than we did. Sorry, this is still new and raw, and really bad at a lot of people, but I did go to a break room and broke a bunch of stuff. I would recommend trying that if you haven't thrown things and broke them with sledgehammers and things.
That's why we like to say lion, let it out now, Lion.
Do you have, we didn't lose her, did we?
Nope, I'm still here.
Oh, okay, good. What do you have advice for a parent, father or mother of a child? What would you advise them to do if they have some kind of pain right from the get-go?
I mean, you have to just keep pushing. We did that, but there just wasn't anybody who knew anything.
Mm-hmm. And did you find, and you found, apparently you feel that they just didn't know anything along the way? The neurosurgeon?
No one brought up arachnoiditis until I said, hey, do you think this could be what we have going on? She should have, we just finished the steroid infusions last week. Like that should have happened last year.
Mm-hmm. Yep. And your daughter, is she in school now to where she's at least?
Oh yeah. Yep.
Is she enjoying any of the usual things that teenagers do? Is she?
Yeah. Yeah, she's in a musical right now. I'm gonna go tomorrow night. She's not in her lead role tonight, so I didn't want to see it until I could see her performing first. So yeah, she finds lots of things to keep her busy. When when she doesn't have stuff, then it's worse because she's not as active and she's
Yeah.
laying in her bed and on a heating pad.
Yeah. Well, you made your point, and I hate to say you're talking to the choir, but we get a few non-choir members
Right.
watching this show. So,
Right.
but there's no question about it. It has been a little discouraging even to me, not a little discouraging, very discouraging, when this disease is just not known even by neurosurgeons and radiologists who've never seen it. And we still have a handful of people who don't know what it is, don't know how to recognize it. But one thing is clear, and even your daughter, they now know about, besides Ehlers-Danlos, there's some other connective tissue disorders that aren't quite as obvious. And she had, my guess is she has one of those. So please keep us abreast of what's happening to her. We'd like to kind of be able to have a diary of kids as to what they should do to grow up and have a decent life. And let me just put it this way: based on what I know about the disease, you're a darn good mother because she's alive and functioning, and I can't say that about a lot of kids who got this. They're not with us, so thanks. Okay, with
Thank
that,
you.
we're going to sign out because I've got a special thing for Mark here that I've got to lay on him. Okay, so we'll sign off here, and thank you so much. Okay, Jamie.
I'd just like to know one thing.
Sure.
Is your daughter's pain being managed adequately?
No, I mean, she still has pain all the time. We have things in place, but I would not say it's managed adequately.
So she's sleepless.
Yes.
She has trouble getting up in the morning.
Yes.
She's impaired at the level of thinking clearly, and she's upset a lot of the time, which an 18-year-old would, or 17-year-old would be anyway. But what could improve her pain management?
I don't know.
What could improve her pain management?
Not have
Is
it?
she on an opiate?
No. I mean, she's doing some nerve pain.
So
pills and
gabapentin?
Lyrica.
Lyrica, yeah. Can she concentrate on that?
Yeah. Mm-hmm.
Okay, all right, good.
Yep, she's a straight A student, so she can't concentrate when she's in pain, and she can't, but it doesn't like knock her out.
Yeah, got it. Okay.
Okay. Marine Field listen in, because Mark, I've got something that sorry I didn't have a chance to brief you on, but I've been too upset. Okay. Jamie, I hope you guys are listening, because I've got something I want to bring to all of you that to say I'm upset is that's an understatement. I have here in front of me yesterday's Wall Street Journal. And there is an article here that shocks me. Okay? And what it is that our federal government, has authorized Medicare and Medicaid payments for some non-medical treatments that I find shocking. And I find them shocking because we see people on this program every week. We see them throughout the week. People can't get their medicines. People have had their medicines pulled and committed suicide. We can't get palliative care. We've got a terrible medical problem. But I want to read you something from the Wall Street Journal, this medical magazine, if you will. Here's what it says. Last month, the Centers for Medicare and Medicaid Services approved waivers in Arizona, California, New Mexico, and Oregon, allowing Medicaid to cover traditional Native American health practices like dance and music therapy. Earlier this year, New York Governor Kathy Hochul amended the state's Medicaid waiver to connect beneficiaries to nutritional and housing support. Leaders in Massachusetts, New Jersey, Vermont, and Utah have created programs effectively prescribing art, nature, and social connection. The push is to have Medicare and Medicaid pay for a social prescription of sports, lessons, art classes, and even food and job support with taxpayers' dollars. Now, this week also, I've never heard of this before. I don't know how many of you out there have heard that your taxpayers' dollars now are willing to pay for art classes and Native American dances, but you can't get your Valium. You can't get your Vicodin. You can't get your Dilaudid. Okay? I mean, I can't believe what I'm reading. Now, what makes it worse, this week I take the two most prestigious medical journals. One is the Journal of the American Medical Association. The other is the New England Journal of Medicine. Now, I would have thought, now as a physician who gets all these publications, that the medical profession might have told all of us about this. Might have asked us doctors what we thought about your Medicare paying for art classes when you can't get, approval to get an MRI. Now, for example, I just love this. The New England, the Wall Street Journal is telling you all about what Medicare and Medicaid is going to pay for. But here are the articles in the New England Journal of Medicine this week. Portraiture is a tool for disrupting structural sexism and racism. Number 2, health equity rounds discussion of medical racism. Number 3, the Menstrual Health Equity Initiative, whatever that is. And of course, the JAMA doesn't want to get left behind. They have this wonderful story here for physicians called Information about Sexual and Gender Minority Services and Policies on U.S. Hospital Websites. So I want you to know, if you want to know what's going on medicine, you read the Wall Street Journal. And if you want to know about transgender issues and art classes, read the New England Journal of Medicine. Okay, now, Mark, you're on. Did you write this? Did you sanction this? Are you behind this movement?
You got me on the spot, Dr. Tennant. So no, I didn't. And I am all for culturally aligned treatments for people who are, of that culture. I think they've been ignored too long. In general, I think that well-being is the foundation of our pain relief system. And, this could be good. The question is, how do they measure the benefit?
That's exactly the point. Yes.
So I think that what I'm worried about is who lobbied whom to do what. And I'm not against these things, but I would like them paying for acupuncture for that matter, because there's some benefits. But I'm not sure that this has been vetted as well as the harm from ibuprofen, for example, or the benefit from oxycodone. So I'm hemming and hawing because this is a shock to me. I don't want to overreact to it because I've been reactive all my life, and I'm trying to train myself out of that.
No, forget it. It won't work. They're going to keep agitating you. But I think good authority that there is a new government office called How to Antagonize Mark This Week.
Yes, yeah. Well, they're located on Park Avenue in Helena, Montana, and they're the Board of Medicine. But I think that without further information, it's hard to assess whether this is a benefit or a harm. But your point is well taken. If we can't get, well, I talked to a patient today whose doctor was afraid to prescribe Soma for her. All she wants is 10 Soma a month, not even daily. and her doctor's terrified to do it because it's part of the so-called Holy Trinity. And I was raised with the Holy Trinity, and they weren't harmful. You know what I mean? And so
Yes.
it seems to me that, and you know, I wrote her the prescription. She's risking, you know, her relationship with her doctor who won't give her what she needs. But it seems to me that, you know, we should be caring for the sickest of the sick, as just as Mother Teresa cared for the poorest of the poor. And get everybody up to the same level. I mean, a rising tide raises all ships, but it drowns a few if they don't float. So I think that, you know, it's at some point, you know, we're going to have to say, is this the best use of our taxpayer dollars? And I think it's a brilliant question. I don't think it has an answer yet.
Yeah, well, that's why I'm bringing it up, that this has been done and nobody knows about it. I mean,
Yeah.
this has got to be, again, they talk about the deep state, and when you hear things like this come out of the blue, you're sitting there reading the newspaper and find out this is going on, and nobody knows about it, and it affects a lot of the country. And at the same time, you can't get 10 soma. I mean, that's ludicrous.
It
So,
is. Dr. Tennant, I wonder, I mean, if I may, I do think it's a beautiful thing to have, say, massage or acupuncture or things like that to be covered by insurance, along with proper relief therapy. But how does a person go to dance therapy or music therapy, if you will, in severe intractable pain without relief? That doesn't make sense to me.
doesn't make any sense at all. And that's, yeah, I mean, there's nobody in medicine, nursing or medicine who doesn't subscribe to that type of holistic social life with these things in there. But to have taxpayers pay for them, that's number one. When we have, it hasn't really been discussed. And again, what I see among the people who are watching this show, and all of you who have these problems, we're a small group. I looked it up this week. Arachnoiditis is still on the rare disease list. So is Ehlers-Danlos syndrome. So is Tarloff cyst. So we have people who have these rare, severe, life-shortening diseases, and we're having Medicare and Medicaid worrying about sports participation more than they are about people who are dying of severe disease. So anyway, I think that's the issue that I want to bring up, and it certainly needs to be discussed. And again, you've got that issue of paying for it. Now, to make matters worse, in the same, and Mark, you listening to this one now?
Yeah.
I've got another one here. I've got another curveball here. In the same issue of the Wall Street Journal, it talks about how all the pharmaceutical companies are now lobbying the big employers and insurance plans to pay for the new expensive obesity drugs. Okay? Now, those drugs are awfully expensive compared to a little Soma or a Vicodin or a codeine. Now, if they start paying for all these expensive drugs through health insurance plans, what's that going to leave for the people who need a nice cheap drug like Vicodin?
Well, you got a great point, because if it's cheap and safe, we ought to be using it. So
Yeah.
I think we can utilize articles like this to lobby for ourselves and say, at some point, let's do the practical thing to keep people employed and paying their taxes. You know, the Institute of Medicine report in 2011 indicated a $625 billion impact on the economy for chronic pain. And that's basically people who leave the workforce, and instead of becoming contributors, they become a drain on our system. We become a drain on the system because we're all in pain. So at some point, we have to, I think we ought to have all the stakeholders together to have that conversation and say, geez, you know, is Ozempic, does it make sense? And it may make sense. It may pencil out to get people's obesity under control when they're in their 20s, because it is a very costly illness for patients. But it should definitely pencil out to give patients their oxycodone and keep them ambulatory so that they're not going to bed consequently having a pneumonia or a pulmonary embolism, and no longer able to work, and therefore now requiring supplementation to their, they go on disability. So I think you raise a brilliant point, and maybe we're in an administration where those conversations can begin to happen, because right now, if you're in pain, you're discarded.
Yes. Yeah, absolutely. You've been very involved in of course, the advocacy movement. I think you guys have made a lot of headway. We're still alive, and I can't say I think things are getting slowly better. Where are we at this week? Give us the advocacy report.
Yeah. I want to bring everybody's attention to the fact that there is Dr. Jeffrey Singer of the Cato Institute is having a session on December 3rd. I put a link in the chat today. So far, we're 3 weeks from the show, and there's 250 people signed up, and usually people don't sign up for the last 2 weeks. So it's going to be a very big event. So it's led off by me with a short presentation, followed by Brandy Stokes and her saga, followed by Kate Nicholson, who helped write the pain law in Colorado, followed by Ron Chapman. And Ron Chapman is an attorney who defends doctors, and he's going to be nominated to head the DEA by Norman Clement. So we're hoping that Ron Chapman takes over
Wow,
the DEA.
that would be great.
That'd be great. So at any rate, it's a policy discussion and not necessarily an advocacy discussion, but as many people as we can get there to show that we have numbers and that we could be listened to, I think would be really useful. So that's my invitation. As far as advocating for my patients, I played you last week this very traumatic conversation between me and a pharmacist who cut off a patient named Monique in Denver. Monique she's found a pharmacy to fill her prescriptions on Friday for her oral pain medications. And I was able to get her a small amount of some injectable hydromorphone. And she finally got it yesterday. And she slept all day, and I was so worried because I couldn't get in touch with her. But she called me at the end of the day, and she said she hasn't had pain relief like this in 3 years. So maybe out of this crisis, she can be recognized as someone who deserves to be treated with respect, with honor, and with compassion, instead of discarded by some heartless pharmacist who doesn't want to fill their prescriptions. So she was in withdrawal, and it was severe. And I have some very poignant video that I've made, and it's on Facebook. And she is gone from hot mess, crying, blowing snot and throwing up and all of that, to smiling with her mother, and she's got temporary relief. Who knows how long it'll last? So miracles happen when we stand up for ourselves. And there's an article about her written by a reporter in Colorado, been sent to the governor. So we've got some follow-up work to do. They have a really impressive law in Colorado to defend doctors, and the law also includes a provision where pharmacists can't reject someone based on their dose of pain medicine.
Wonderful. Could we? I've been wanting to do this for some time. You've now had a lot of experience with the new high potency, ultra potent dilaudid. In my opinion, and keep in mind, I grew up in the days when we really did use the Bronfen cocktail. We've had lots of people on intrathecal pumps. We've had the fentanyl patches, the fentanyl lollipops. I do not believe there's better pain relief than this dilaudid that's made 50 milligrams per ml, or they can use it by an allergy or insulin syringe subcutaneous. And it lasts a lot longer than you think it's going to last. Can you give us a little experiment? Because I've got a lot of doctors for the first time and nurse practitioners asking about this. And this is really good because it really is what should be used for palliative care. it's a great advance. Can you expound on it a little bit? Because I'm getting a lot of inquiries about it for the first time.
That's great. That's great. We're going to need some other compounding pharmacists. We're going to need a bigger boat, so to speak.
There you go.
Because they were down from the hurricane, and it was costly for many patients. And I'm not sure how much capacity they've got to expand. So we might need to find some other compounding pharmacists to do this. And maybe you and I can talk offline about how to create that, because
Yeah.
you were the mover to get them to do this in the first place. I don't know how you got them to do it, but thank God you did. And there are hundreds of patients who are benefiting from it. So I'm gonna ask another question back. What is the right dose of pain relief for a pain patient?
I go
Enough.
with I go with the old school.
Yeah.
You got to have enough opioid, first off, to think, to walk, to use all your functions, and above all, enough to analyze and also to have some happiness on a chronic basis. But it needs to be a high enough dose that the blood pressure normalizes. Your pupil still reacts. In other words, this is not hard stuff.
It's not rocket science. It's not
No.
even complicated medical science, because I
That's
can
right.
do it. So
Yeah, you've got a point there.
yeah. So I ran into a patient today on 10 milligrams of oxycodone 3 times a day. She went and had her mastoid, the bone behind her ear, taken off. And the surgeon prescribed some additional medication for her, and her family doctor canceled it because it was more than 50 MME. And the family doctor is like, I have not talked to that person. I don't think I want to for a couple of weeks. But maybe I could at that point. But it seems to me that what doctor can call up and cancel what another doctor prescribed for a patient? Who owns this patient?
Yeah.
And what kind of, is it slavery? I mean, is it plantation? What is going on where a doctor can have they don't have the cojones to prescribe the right dose, but they've got the cojones to interrupt someone else's opinion that they should be treated. And it just, of course, it steams me. So at some point, we've got to get this MME thing out of there. It's just highly destructive.
Yeah. I think maybe next time, one of the subjects that I was going to bring up today until I read this thing about the art therapy rather than Valium, but the insurance companies, Reader's Digest has made the comment that 75% of physicians in the country now are either employed or contracted to a health plan. And this doctor reminded me, this guy calling you, he may be having the pressure put on him by his employer. And so today, patients need to start understanding that when you can't get your treatment that you want, you're going to have to contact the CEO of United Health, and we can supply those names. And we're moving into that era because the physicians no longer can make their own decisions. And even when you start reading on what they're publishing in medical journals these days, it's not things that help the average doctor practice or the average nurse practitioner practice. It's junk. It's the journals have become terrible. I still review for several and was an editor for many years, and they've turned the journals all into either trade unions or political causes, and that's been unfortunate also. So we can maybe hit that next week. But anyway, on your conference coming up, I'm so glad you're bringing this up. And Jamie, to close out here, can we make sure we get that conference well organized and also get me some stuff, because I want to make sure my mailing list and my websites advertise that thing. It's going to be dynamite. Okay.
Yes.
Thank
With that,
you.
Mark, any last comments? Jamie, Mark, you've got about a good 30 seconds left.
Well, to follow up on your talk about medical centers and research journals, the other thing to consider is that the medical centers used to take on the most challenging patients, and now they don't, because it's a risk to treat a challenging patient. So somebody told me this the other day. The Cleveland Clinic says, we're here for your well-being and your health, and now their motto is the Cleveland Clinic, we're here for your safety.
Interesting.
It's not very safe to get sick in America today. And if you give up freedom in order for safety, you're going to have neither freedom nor safety. So I think that medical freedom has got to be up tops on our list in terms of how do we get our doctors empowered again, which means we need some powerful loudmouth doctors with a spine to express this stuff. But at some point, we've got to say, free the doctors. Come on. That's all.
Now, I have one question for you. Has Cleveland Clinic started art and dancing classes yet?
No, no. But
Well,
but
that's
but
all
you know
right,
they
too,
can
if
they
give
they get a
little
lot of
medicine.
money from foreign patients, and the technology is beautiful and they're really good and they did a great job on my bypass. They didn't treat my pain post-operatively very well, but I recovered, so it's okay. It was acute pain, and the thing I learned about acute pain is that acute pain gets better every day. So no matter how severe it is, tomorrow's going to be better. Chronic pain doesn't. And so tomorrow is going to suck worse than yesterday. And the future that you have to live into with chronic pain without relief is a very dark future. If you're dying from your pain, you have a job to do. Or if you're dying from cancer, you have a job to do, which is get your affairs in order, tell your people that you love them, and there's some steps to take care of, and you have a job. Basically, get your shit together before you die. But if you're dying, if you have pain and you're not dying, you have an endless lifetime of dark suffering to land, and we got to stop that.
Absolutely. Let's close this up with a new motto: stop the darkness. With that,
Thank
let's
you.
have a little light this week, and we'll see you
Okay.
next week. Bye-bye.
Thank you. God bless everybody.
Yes, thank you.
Thank
God bless
you.
everybody.
God bless you all.
Thank you all so much. Good night. And everybody's welcome to unmute. And if you want to shout out and say good night to everyone, you're more than welcome.
Good
Night,
night,
Jamie.
everyone.
Enjoy your
Bye.
enjoy your
Thank
dance
so
lessons.
much.
Night, everyone.
Night.
And God
Good
bless
night,
you,
everybody.
Michelle. Love you guys.
Night.
Praise God. Good night,
Love you
everyone.
guys.
Take
Love
care.
you.
Good
Good
night,
night.
all. Good night.
Bye-bye.
Love you.
Bye.
Love you, Jamie.
Good night. Good night. Good night.
Good
See you
night.
next week.
Good.
I can't
Thanks
shut
for
myself
being
off.
here. You did a
Mhm.
great job, Michelle.
Good seeing you.
Michelle was the voice for so many other Michelles out there and for so many children out there. Yes.
Good night, everybody.
Night.
Night.
Good
God
night.
bless you all.
Good night.